I'm just going to go ahead and I'm going to share my screen here for just a moment. Go back to that and go. Okay, everybody. Well, welcome to our next episode of Probing the Literature, which is the Ultrasound Journal Club sponsored by the ACEP Emergency Ultrasound section and SAEM Academy of Emergency Ultrasound. And our topics today is going to be resuscitation. So my name is Petra Duran-Gehring, and I'm on the leadership team for this. And so I'm going to go ahead and just kind of quickly run through what our plan is for today, and then we'll get cracking. So we're going to be discussing two articles. If you've never joined us for PTL before, our first one is going to be our authors actually joining us today. And then we're going to break out into small groups after that. And then once we get back in after small groups, we'll have some closing remarks and then methods consult. So if you have any great burning research questions, we'd love to hear it. If you can, please turn on your camera. We'd love to see your faces. And then just making sure that your name and your position, if you're a med student, resident, fellow, we would love to know. And so our first article is going to be a case report. We've never done a case report before on PTL. And I thought this was a great opportunity, especially with our fellows getting ready to transition to go out into private practice. This will be a great way for them to kind of see an awesome case and hear from our authors. So the case is actually a woman with dyspnea and acute respiratory distress. And then our two speakers are going to be Jackie Shibata, who is the Associate Director of Emergency Ultrasound at UCLA Olive View. And also we're going to have Teresa Liu, who is currently the AEUS president. And she's also the Associate Director of Emergency Ultrasound, Director of the Affiliated Clinical Ultrasound Fellowship at Harbor UCLA. And so thank you both so much, ladies, for joining us. And so I'm going to go ahead and let you guys take over. I'll stop sharing my screen. And so we'll let you guys present your case, and then we'll discuss more about what you did.
All right. Oops. Thank you so much. I'm attempting to share here.
Jackie, why is your name Teresa Liu?
I used your link, so thank you for that. I tried to change it. I haven't been able to yet. I'll work on that. My name is actually Jackie Shibata. But, you know, if this lecture goes terribly, you can remember Teresa Liu. That's okay. Just kidding. All right. So thank you for having me. We'll just jump right into the case. This is a case report, so let me tell you about the case. So it's a 37-year-old woman with idiopathic pulmonary hypertension, pulmonary artery aneurysm, pericardial effusion, pulmonary valve regurgitation, diabetes, and she had COPD, was on oxygen at home. But she came into the ED in significant respiratory distress. She had an increased O2 requirement and bilateral pedal edema. Her vital signs were right on the fence. And she looked terrible. She was like sitting straight up, retracting, had accessory muscle use. Her lungs were actually clear bilaterally, which scared me more. She had a 3 out of 6 systolic and diastolic murmur, trace pitting edema, and no calf tenderness or erythema bilaterally. So this was a woman who, to me, looked like a ticking time bomb. She just had a very scary medical history, and her vitals were, you know, right on the verge of going one way or the other. And so, of course, we brought the ultrasound machine over, and this is what we saw. All right, so I'm going to orient you a little bit. We're in a parasternal short axis view. This is, if you slide up from your typical mid-ventricle parasternal short, you get, if you slide up toward the base, this is supposed to be your like Mercedes-Benz view. You can see the little aortic valve right there. Your right ventricular outflow tract would be over here. Here's your pulmonary artery, which normally isn't this huge, but she had very bad pulmonary hypertension and a pulmonary artery aneurysm. And then what we saw that was new for her was this thing flapping in the wind right here, which was a pulmonary artery dissection. Scary stuff. So, oh, sorry, this is to help orient you. This is what the view should look like. All right, and then we put color on it, and you can see that there is flow both in the false lumen and the true lumen. All right, so the why. Why did we choose to do this case? Well, it was a really cool case. I mean, it was it was a really scary case, one of those cases that like still gets your adrenaline up, even as like seasoned emergency physicians. And as an ultrasound fellow at the time, I had no idea what I was looking at. I don't think I even knew about that parasternal short axis view at the time. It was early on in my fellowship. And so I had seen that she had a large pericardial effusion, which was very scary to me. But thank God Teresa was there. I was like, Teresa, come and look at this. Can you orient me here? And she's like, I think this is the pulmonary artery. And I was like, what? And I had never seen a pulmonary artery before. So I really learned a lot from doing this case about ultrasound, anatomy, and this new pathology that I never even knew about. And the reason I don't think we learn about this typically in emergency medicine is because there's only been 100 cases reported in the literature, period. And most of those reports are postmortem. And my mentor told me to do it, so I did it. Do we do everything our mentors tell us to do? No, you have to pick and choose. But honestly, they've been through it. They know better than we do. And when she was like, wow, this is a really cool case, I knew it was a really cool case. So we saved a lot of images. But of course, that has to intersect with your own personal interest. I found this really personally interesting because I have a close friend who's in her 20s who has really, really bad pulmonary artery hypertension. And she's always asking me about complications that can happen. And this was our patient in this case was a young woman who I also related to and still think about. And so all of those combined to be like, yes, of course, we have to write this up. So the research question, what's the role of ultrasound in a PA dissection? How common is this? We really didn't know anything about this pathology when we saw this case. Has anyone used point of care ultrasound to diagnose this in the past? You never know. I mean, point of care ultrasound people are out there like doing all kinds of cool stuff. And then, so ultimately it sort of became a literature review in the beginning, but there wasn't that much literature out there. It was mostly just case reports, case series. And then I think there was one sort of like narrative review. And so why we chose to do a case report, I mean, it's a rare pathology, so you're not going to be able to do any sort of like prospective study. Again, it was a really stunning case. It's the kind of case that really sticks with you. And there was no reported use of POCUS for this in the past. So that made it the perfect setup for a case report. So this is what I came up with when I was making this presentation, but I was like, this isn't like really, are these good learning points? So I cheated a little bit and I asked ChatGPT, why should you do a case report? And this was what it came up with. Really, when you're doing a case report, you have to think about uniqueness, educational value, clinical significance. So is your case unique or unusual? Yeah, ours was. Educational value, does it provide new insights about the condition? And did you demonstrate how POCUS was used as a diagnostic tool? Yeah, we did. Clinical significance. How did POCUS use influence, diagnosis, management, and treatment? Well, in this case, it really changed the diagnostic test that we got. We went straight to a CTA, but of the, I don't remember how we timed it, but obviously, we had to talk to radiology. We got our surgeons, our thoracic surgeons involved really early. And so, yeah, it definitely changed the course of her care. So ChatGPT came up with a couple extra things also that I cut out because they were just irrelevant. But I mean, this is pretty good. If you guys aren't using ChatGPT, play around with it. It's pretty fun. I can't share what else I've been using it for, but it's really helpful. Let's see. All right, so discussion. This is a fatal condition. Like I said, it's usually diagnosed post-mortem. But with better treatments for pulmonary hypertension and people with congenital heart disease living a lot longer, the prevalence of people having these kind of conditions is actually increasing. So you're having higher pressures going through your pulmonary system for a much longer time. That's leading to actually more PA dissections. So we might start seeing more of these. It's just something to have in your back pocket, I guess, if you ever see a giant globular structure in someone with pulmonary hypertension. And you can make the diagnosis rapidly with POCUS, and it really can change the outcome for the patient because this is time sensitive, and we were able to get the right consultants on very early and start treatment. She had to be on a diuretic drip, and she had like really crazy pulmonary dilators, and ultimately she got transferred for a heart-lung transplant. All right, so now let's talk about the lessons. I love this quote. The only mistake in life is the lessons not learned. So we'll talk about what lessons we learned from doing this case report. Because even though it's just a case report, there's always something to learn. I mean, medically, we learned a lot, but I do not come from a big research background. And so I think this was my first ultrasound publication. And it really helped just going through the process of like writing it up, submitting it, getting rejected, resubmitting it. That you learn a lot from that process. And so even a case report can be a really helpful experience. So number one lesson, listen to your mentor. So Teresa Liu, she's here. She was the senior author on this paper, was there that day in the emergency department. Thank God for this patient. And just has a lot of life lessons that I think a lot of times we take for granted, because we almost, when you're an ultrasound fellow, you're like, oh, I'm an attending now. And like, I've made it and I'm really good at what I do. And yeah, we're all good at what we do. That's why we're here. But our mentors are better. They've been here longer. They've been through it. They've seen it. They've published a lot more than us. They've hit the, have overcome a lot more obstacles than we have, and they have a lot of insight. And so I think picking good mentors, people who really want to lift you up, is important. And then when they give you advice and say, hey, you should actually spend your time doing something like this, it's worth listening to. Next up is that one small success can snowball into big successes. So this started as a little case report. And then I wrote it as an abstract and then turned it into a poster. And then, which by the way, Teresa pushed me all the way down to like this step, I think, and then ended up submitting it to Win Focus and got to go to Dubai, which was super fun. And I met a bunch of people and networked and did the whole conference circuit thing, which is cool. And then actually got a publication under my belt, which feels good. And like I said, gets you ready for the bigger publications. So then I started publishing more and feeling more comfortable with that. That helps with academic promotions. And then it leads to the ultimate success of being at the ACEP SAEM Ultrasound Journal Club. I kid, but at the same time, it's like these sort of things, these opportunities don't come, it wouldn't have come up if I hadn't done this little case report in the beginning. So the effort to do the case report, it took some effort, and it was sort of like a drag when it wasn't getting accepted into papers, but then it's totally worth it because there's a lot of success that can come after from putting in that work the first time around. And so, the second thing I would say is that, try to maximize your academic credit for every effort that you do. So I'm sure you guys have heard this, but I think it's worth saying again, that if you put in the work to write up a case report, make a poster out of it, submit it for an abstract, lecture on it. If you've put together a lecture for one thing, ask your residency, hey, can I lecture on this at the next resident conference? And now you have multiple lines on your CV that all started with the same baseline amount of work. Each one you have to, of course, change it a little bit, but to come here and talk about it today was pretty easy. The work was done, and now I just get to talk about it and, listen to your mentor. My mentor texted me this morning. I was like, remember, this is a national talk. And so that's going to go on my CV as a national talk. And so it's, these opportunities just seem to, it gets easier once you've already put in that initial work. All right. And every journal has a home. Someone just said this to me yesterday. So when you're submitting for publication, try again, try once more, try differently, try again tomorrow. We submitted to New England Journal. I know, it's worth a try, right? We got rejected immediately. I think they sent a rejection email that day. And then we sent it to CHEST and then JUM and then waited years. And then Teresa's like, please try to submit this again. I said, oh, okay. And she's like, just submit it to JSEP. I did it. Thank God they accepted it. And so it was our 4th submission. So, don't give up, ask for help, find someone, just keep trying until you succeed. And again, that's the process. I didn't realize that was the process at the time. I'm like, man, I had such a cool case. I did all this hard work. It should get accepted. That's not how it works. You get rejected. You have to do edits. There was one paper that I submitted that we had I don't even know, 6 rounds of edits back and forth, and it was so painful. But it's just, that's just the process, and it becomes less painful once your expectations change and you're like, okay, this is the process. I know this. Oh, and get it done. I put that reminder here because so we waited a few years between our first attempts at submission and then when it actually got submitted. And I see some of you nodding your head. You've probably gone through this before, but you have to like recreate the wheel all over again. You're digging up like your old emails and consent forms and versions and images. And it's just, you're reusing a lot of the energy that you already put into this. So once you have that momentum, set deadlines for yourself and just get it done. This is something I'm still working on for myself, but if you get rejected, the next day you should be looking at where you want to submit it to and just keep up that momentum. All right. And then finally, get consent. I think this is, you know, with case reports, it's not a planned research study. So it doesn't, you don't like think about, oh, we have to like get all of our patients' consent and submit an IRB and all these things. So if you have a really cool case, a lot of times patients are lost to follow up. And so especially in our hospital system. So, you know, if it's cool, ask the patient, grab a consent form, print it out. Like, can I use these images for publication to teach other people about this cool pathology? Maybe don't word it that way. All right. And I think that's it. Let me stop sharing.
Awesome. That actually, I think that's something that, you know, a lot of us have those really cool cases, but it's taking the time to actually get them published, I think is the really big difficulty. I love what you said about that getting consent. I tell my residents this all the time. If you have a cool case, just go and consent the patient for photo images. And that way, even if you never get around to writing it, at least you're prepared, because the worst thing is trying to track down that patient much later on. So I agree 100%. Now, when you were doing this, did you go to, did you submit it for publication at the same time that you were submitting abstracts and posters?
Yeah, I did we had submitted it. Yes, in the first round when we were trying to submit it, we submitted in an abstract at the same time. And so I had a poster that I went and presented on before it was ever published as a case report. So yeah, you don't even have to have it published to be able to go to a conference and get your conference fee waived, you know, travel to a cool place, meet cool people. So there's a lot of benefits that can come from it, even if you don't publish it.
And I think that as you called it, double dipping is something that I think a lot of times that is underutilized in academics, because that's something that each one of those times you do it is a line on your CV, and all of that kind of adds together for academic credit. I see, Teresa, I think you had a question or something you wanted to say.
Yeah, I just want to, Jackie, thank you for, doing all the work. So I don't have much to say here, but two things. So I just wanted to add that another reason I think to publish the case report is really like, you know, I'm the cheesy person. I'm going to come from like standing on the higher moral ground, is that we really want to share something with our community and think that it's beneficial to the community. Something that is rare, but has like such a, you know, wow, shock value. Like when you feel it, you can see that how that can benefit your colleagues as well. And especially for a case like this, I was like really pushing Jackie to get this published, because part of what her research showed is that this is so rare, but it's increasing. It's kind of like those pediatric congenital heart patients we see more and more as adults. Same thing, the more that we're getting better at treating these idiopathic pulmonary hypertension. So this could become not so rare in the future. And so you have to think that, you know, this has to add value to your community, to the scientific literature. Then that really will also motivate you from like, you know, that place to say, get this out there. And how many times have I talked to my trainees about this, and that? And I was like, and then there's a case report, you know, and so it adds to that. And then the second thing that I want to add is that, you know, Jackie did a really good job orienting you guys on the images. But I will tell you that both, like I was on the clinical shift, she was the fellow coming in for a scan shift. I was like, oh, go scan this shortness of breath woman. I had no idea what she was going to find. And when she called me to the bedside, I have no idea what I was looking at. None of us, that big, gigantic thing was just in your face and you can't take your eyes away from it. So my second point to make here is how to identify something when you have no idea what it is. And the advice is to not completely ignore what's catching your eye, because you cannot stop looking away from and you cannot stop looking at it, but to look away from it a little bit and identify the part that you can see. Go back to the part of the anatomy that you understand and then trace it toward there. It took a while, and your eyes and your brain keep telling you that's not right, that's not right. But it takes a while to make sense of something you've never seen before. And this was one of those cases. And it's obvious now, because now we explained it and stuff like that many times, but it was not obvious at all when we first look at it at the bedside.
Yeah, I definitely agree with you. When you showed the initial image before the orientation, like, that's really, really kind of confusing. But I think that's something to kind of like think about when you're scanning, because you're always going to have something like that, where you're going to have something you're like, what the heck is this? And to kind of take that moment, figure out what it is. And then if it's something unique and interesting, that if you're having difficulty with it, then I bet someone else would too. And so that's really what you're saying, Teresa, like being that kind of resource for the rest of the community. Dr. Melniker, I think you had a question.
Yes, can you hear me? I'm driving, so I don't have my video. Yeah, terrific case, really awesome. Great job on the presentation, great job on the mentorship. Cases like this really drive home an important point, and that is, if you haven't looked at your anatomy textbook recently, pull it back out, or whatever media you used to learn anatomy. I'm dating myself by talking about books. And flip through it all, and don't read a word. Just memorize the pictures, because you get cases like this where the anatomy is so distorted, unless you know the normal really well, and you could step back. Oh, what is this big blob and this flap? Oh, this is this, and you go through each structure, and you'll realize, oh, that's got to be the PA with a dissection flap. And the other critical point that's already been made is that this will only become more common. I first picked up a probe in 1990. In 1990, if someone was found to have HIV, that meant they were going to get AIDS and they were going to die. Today, people live long lives and have kids after infection with HIV. Similarly, pulmonary hypertension was something that was found at the very end stage, and it meant that person was going to die soon. But because medicine has gotten better and continues to get better, people are living a long time with pulmonary hypertension. So this kind of entity will only become more common. It's a great presentation, and thank you for allowing a case report to be presented at this journal club.
Thank you so for those comments. And it looks like Lindsay Taylor made a comment here that about HeartWorks. Great point. If you have HeartWorks, which is, that's a brand, I'm not advocating for any specific brand, but it's a great simulator for cardiac images. And so working through that, I think, and Lindsay, you can probably comment some more on this, that, is a useful tool for you to kind of see different anatomy and see different types of pathology. So you get comfortable with that.
Yeah, I was just agreeing with Dr. Melniker. It's like, even though we, I think I know the anatomy pretty well, but when you really dive in and you can correlate it with the ultrasound image as well, and like, oh, okay, like just seeing it in all different views. I actually really picked up on it when I was doing the TE training for myself. But I think TTE, obviously, it works for all of it. If you can like know the ins and outs and what's anterior, what's posterior, and okay, if I slide anteriorly, I should see more aorta, et cetera. So it's really, if you can afford it and or get your program to get it, that would be ideal.
Great. Well, thank you so much for presenting this case. This is such a cool case. And just for you, kind of a plug for the upcoming SAMEs, which are the SAEM Best of the Best articles, ultrasound articles of the year. This was actually nominated for a SAME last year. Our second article is also nominated for a SAME this year. So if you are part of SAEM, this is the time of year to vote for the Best of the Best articles. All right, so thank you again so much for coming to speak with us. We're going to then go ahead and break into small groups. Our second article, hopefully everybody doesn't kill me for the second article. I'm just going to share my screen so you can see which article it is. Since it is a little bit more complex. So our second article is a really nice article by Tony Weeks. It's talking about PE and what are the predictors of clinical deterioration on ultrasound. So this was a really kind of dense article. So we're going to try and break this down as best as we can. So we're going to break into small groups. Dan's going to get us into small groups. And then after that, we're going to kind of discuss it in small groups if you haven't been with us before. And then we'll come back and kind of everybody can kind of give 1 or 2 points of what they thought was interesting about the article. Oh.
Is this the right group? I was put into a group initially, then got kind of kicked out and back here now.
Yeah, I'm trying to figure out how to get you back in because it doesn't show you as an unassigned person right now.
Oh yeah, it was interesting. It came up and said something about how my status was being something, so I clicked X and then it kicked me out. So I apologize for that.
That's okay. All right, I will find a way.
Would it be helpful if I like exited out and then
Yeah,
tried
well,
to
if
click
you
the
exit
link
out
again?
and then come back, yeah,
Okay,
I think that would be good. Exit out and then come back in and I'll reassign. And Shane, you can do the same thing. All right, let's try this again. Here we go. Do you have a preference on where you want to go? All right, let's just put you guys.